A 73-year-old woman presented for treatment recommendations for recurrent metastatic breast cancer in 2010. She was initially diagnosed with ductal carcinoma in situ in 2000, following an abnormal mammogram. Her past medical history was significant for hypertension, hyperthyroidism, and a hysterectomy and unilateral salpingo-oophorectomy at age 28. Her home medications were hydrochlorothiazide and levothyroxine, and a prolonged use of oral hormone replacement therapy. Her family history was significant for ovarian cancer in her mother and maternal aunt and prostate and colon cancer in her father. Given the family history of ovarian cancer and her desire to continue hormone replacement therapy, she underwent bilateral mastectomy with breast reconstruction and an oophorectomy. Pathology of the left breast revealed a high-grade, 1 cm ductal carcinoma in situ. She declined genetic testing and received no further therapy. In 2010, the patient underwent an assessment in preparation for an extensive reconstructive foot surgery, which required bone marrow harvesting and stem cell engraftment. A PET-CT revealed a single hypermetabolic mass of 2.3 x 1.8 cm in the right lobe of her liver. A biopsy revealed this was a poorly differentiated adenocarcinoma, consistent with a breast primary. It was ER/PR positive, HER2 negative. She stopped her hormone replacement therapy when the diagnosis of metastatic disease was made. Her physical examination was unremarkable except for prior bilateral mastectomies and implant-based reconstruction. The patient was started on endocrine therapy with exemestane. She described multiple symptoms and was not able to tolerate the medication. She was prescribed anastrozole, which was associated with a syncopal episode. Since the patient had an oligometastasis, she underwent a partial hepatectomy in April 2010, which revealed metastatic adenocarcinoma. Following the hepatic resection, she declined endocrine therapy. She was followed regularly with clinical examination and PET-CT imaging every 3 to 6 months. After 3 years of follow-up, PET-CT revealed a new single hypodense lesion in the liver measuring 2.6 times 2.8 centimeters. The patient underwent a second hepatic resection in June 2013. The patient again declined endocrine therapy and was with no evidence of disease until June 2014 when multiple new hepatic lesions were seen on PET-CT. Since she was not a candidate for resection, the patient started letrozole and has taken the medication despite significant bone pain and dry mouth for approximately 1 year when a PET-CT in June 2015 demonstrated disease progression with multiple hepatic nodules and mediastinal lymph nodes, Figure 1. The patient was started on fulvestrant and palbociclib in July 2015. She received 1 injection of fulvestrant and described significant flu-like symptoms, including a cough and diffuse aches. She declined day 15 dose, and did not take her palbociclib. She was agreeable to a second dose of fulvestrant about 1 month following the first injection and also started palbociclib. She again described significant side effects and declined endocrine therapy. She also declined chemotherapy and asked to remain on single-agent palbociclib. Given few available options, the patient was maintained on palbociclib, which was adjusted to 100 mg by mouth daily for 2 weeks with a 2-week break based on her complete blood cell counts. She tolerated this dose and schedule well with no neutropenia. An initial follow-up PET-CT in September 2015 revealed near-complete metabolic resolution of the metastatic disease, Figure 2. She remained on palbociclib alone and was monitored with clinical evaluation and PET-CTs every 3 to 6 months. However, after progression-free interval of 20 months, her PET cohort in June of 2017 revealed disease progression in the liver and locoregional lymph nodes.